Hi, I'm Dr. Lora Shahine. Welcome to my YouTube channel. Today, you're going to learn all about fertility testing. I'm Dr. Lora Shahine. I'm a reproductive endocrinologist with over 15 years experience helping people build their families. And today I want to teach you the basics and all about fertility testing. So whether you are getting ready to start trying or whether you have been trying to start or complete your family for a while and it's just not happening as quickly as you thought it would, it's time to schedule an appointment and get some testing. And it can be nerve-wracking. You might not know what to expect, but it's important if you learn a little bit about the testing, then it's going to make that first visit much easier. You can have your questions ready and really be an advocate for your care. So the basics of fertility testing are, we got to make sure all of the pieces are there. Do we have eggs? Do we have sperm? And how is the anatomy? So how do we know we have eggs? Well, if someone is having regular, predictable menstrual cycles about once a month, then they are most likely ovulating about once a month. It's amazing how much coordination and communication goes on in the body with hormones, connecting from the pituitary gland underneath your brain to your ovaries to your uterus, and everybody communicating with each other in order to have regular, predictable menstrual cycles. And part of that communication is ovulation. For about 2 weeks, the egg matures, and then we ovulate, and then about 2 weeks later, we get a bleed or a menstrual period if we aren't pregnant. And so that cycle takes so much coordination. If you aren't releasing an egg, if you aren't ovulating, you will have very unpredictable menstrual cycles. Unpredictable, it doesn't mean being off by a couple of days. Very rarely do people actually have a 28-day menstrual cycle like clockwork every single 28 days. That's rare. You could have a cycle that's like, and when I talk about cycle, it's from first day of bleeding, cycle day 1, to the next day of first day of bleeding and that following cycle, you count that. If it's 28 days between that, that's a 28-day menstrual cycle. And so some months it could be 27, some months it could be 31, but if it's pretty regular, if it's pretty predictable, most likely you are ovulating. Sometimes people can have bleeds that are not associated with a previous ovulation, but again, you're most likely ovulating if you can predictably rely on a period about every 4 weeks, okay? So you have eggs, most likely if you're ovulating regularly, but a part of fertility testing is actually thinking about the egg quality and the egg quantity. And the way that we can figure out that is through some blood tests and through an ultrasound. So the way you can figure out ovarian reserve or egg supply, there's so many different confusing terms for this, but that's what we're talking about. And you'll read all different types of things and providers might say different things, but you're just trying to figure out, are there eggs? How many are they? And are they okay? So for blood work, looking at your egg supply or your ovarian reserve, there's actually 3 blood tests to look at. Number 1 is follicle stimulating hormone or FSH. Number 2 is estradiol, and number 3 is AMH or anti-Mullerian hormone. FSH and estradiol are typically done on the beginning of your menstrual cycle while you're bleeding, typically on cycle day 3, but it can also be on cycle day 2, 3, or 4. The AMH level, that can be done really anytime in your cycle, but just for ease, often you'll do it at the same time as the other blood tests. You just get one test and get all this information. The reason that we do the FSH and estradiol at the beginning of the menstrual cycle, cycle day 2, 3, or 4, is that is the standard that we're used to checking, and it's when the FSH should be the lowest in the cycle. FSH is a hormone that comes from your pituitary gland to talk to your ovaries to help recruit and mature eggs. Follicle stimulating hormone. The eggs are sitting in little pockets of fluid in our ovaries called follicles. And this hormone is coming from the pituitary gland to encourage the ovaries to recruit, mature, and ovulate an egg. So an FSH level that is high at the beginning of your menstrual cycle can be a sign of poor ovarian reserve or maybe poor egg quality. And the way I explain it to my patients is it's like the ovary is requiring more bribery, more money to kind of do its job. It'll ovulate, The ovary will recruit an egg and ovulate, but it's going to require more of that FSH from the pituitary gland to do its job. I've often heard it described as like the FSH is like gas for a car, and the car is like actually ovulation and the regular menstrual cycles. And the FSH, if you have to press really hard on the gas to inject the ovary with the energy that it needs to do its job, then that's a sign that the ovary is kind of pooping out a little bit. I know that doesn't sound very scientific, but it's okay. Like, you need to kind of understand this. I really want to educate you. I don't want to just say, oh, a high FSH is a sign of poor ovarian reserve. You kind of want to understand exactly what's going on in the body, right? So you can ask questions and advocate for your care. The reason that we check estradiol at the same time as FSH is that they're interrelated. And estradiol is just one type of estrogen. There's different types of estrogen that are made from your ovary, but estradiol is the one that we check at the same time as FSH. If the estradiol is high, it can falsely lower the FSH. And so you always want to check these two together, because if for some reason the estradiol is high, you might say, gosh, we might need to repeat this test because we might not have an accurate, relevant FSH level to really know what's going on with your fertility. So what's a normal, I hate the word normal, by the way, who defines what's normal, right? What's a reassuring FSH or estradiol? Typically an FSH that's less than 10 and an estradiol that's less than 80 is reassuring and kind of what we would like to see when we're doing this fertility testing. If the FSH is very high, if it's over 20, that can be a sign of really significant low ovarian reserve, or maybe poor egg supply, maybe poor egg quality, and maybe poor response and poor outcomes with fertility treatment. This stuff is not black and white. Like, you'll often hear me say like multiple terms like ovarian reserve or egg supply or things like that. And it's just kind of like, we're just trying to sort of say, it just might be harder for you to get pregnant, or you might have a lower success with fertility treatment if your FSH is high, right? If your FSH is between 10 and 20, then it's really important to talk to your doctor. Every lab is a little bit different, but in general, the higher it is above 10, sort of the lower ovarian reserve. So talk to your doctor about your results in combination with a lot of other information. The other blood tests that we often do when we're trying to learn about eggs is AMH, or anti-Müllerian hormone. AMH is the supporting hormone that comes from supporting cells around the egg, granulosa cells. So it's not actually coming from the eggs, but the higher the AMH, the more supporting cells and the more eggs you probably have up for grabs. Now, it's not a reflection of your overall egg supply. It's a reflection of kind of the number of eggs that are recruitable, available for recruitment if you were to do fertility treatment. So if someone has an AMH that's high, we sort of say, hey, if you were to do fertility treatment, say something like IVF, or trying to stimulate the ovaries, then if the AMH is high, then we're going to be able to get a lot of eggs. And more eggs means more embryos and means a higher opportunity of being successful, because there's just more to choose from. I think it's really important to realize that no blood test is going to tell you whether or not you're going to be a parent. As long as you're ovulating, all it takes is one egg and you could get pregnant. These blood tests and ovarian reserve testing in general is best used to predict responsiveness to ovarian stimulation, results with fertility treatment like IVF or other fertility treatment. And it just helps set expectations, but it does not dictate your path. Too many patients have come to me and said, a doctor told me my FSH was too high, I'll never get pregnant. But yet they're still ovulating. And many of those patients have gone on to get pregnant naturally. I know it can feel hopeless when you get these disappointing results, but remember, it just takes one egg and one sperm and all the stars aligning, and it can happen, okay? So really, these blood tests are best at interpreting and sort of helping somebody figure out expectations for fertility treatment. So don't just take these results as blanket, fertility outcomes or whether you're going to be a parent or not. Really have a very thorough discussion with your doctor about what it means to you. And everybody's numbers need to be interpreted differently. An AMH of 2 and a 25-year-old is very different for an AMH of 2 and a 45-year-old. So everything has to be taken into context. We're still learning about what normal levels of AMH are. Most of the AMH tests that have been done in the last, few years, it hasn't been around as long as FSH. Has been tested in patients that are having difficulty conceiving or patients that are getting ready to do IVF. So we don't have a lot of data from the general population about what normal AMH is. In general, in your 20s or young 30s, I kind of expect the AMH to be around 2, maybe 3. In your mid 30s, I expect it to be around 1.5, hopefully 2. By the time you're 40, it's typically around 1. And it's typically something that goes down with time, but I got to tell you, I have seen 25-year-olds with AMHs of 0.7 and they conceive naturally. So it's just, don't let it define you. Okay. I have a lot more information about how to interpret ovarian reserve testing on a blog post on my website. And the title of the post is "Do Not Let Your Ovarian Reserve Testing Define You." So learn more about it and take it in context and really talk to your doctor about what it means to you. Another way that we can learn a little bit about egg supply is when we do a pelvic ultrasound, we can look at the ovaries and we can actually count the number of little follicles that are sitting there. They just look like little pockets of fluid, little black dots. The ovary could be considered like a cookie, and the little black dots are sometimes called little chocolate chips in the chocolate chip cookie when you look at a black and white ultrasound. And when we count those follicles, we call it an antral follicle count. And it just gives you a window into how many eggs are up for grabs each cycle. I kind of think about antral follicle count as being sort of subjective way, because sometimes it's hard to see the ovaries, but you can kind of get a general feel sort of subjectively, how many follicles are up for grabs or eggs are up for grabs. And then AMH is a little bit more like objective or a little bit more quantitative, the blood test kind of looking at egg numbers. So that is how we figure out about eggs. So it's blood tests and an ultrasound. The blood tests are FSH, estradiol, AMH, and then you can do an antral follicle count with an ultrasound. So that's what we do for fertility testing, looking at eggs. Next, we need to think about sperm. We have to have sperm in order to have a baby. And so we cannot assume that just because someone has no symptoms or issues with performance or ejaculation, or they feel healthy, we cannot assume that they have sperm. There are times where people have what seems to be a normal ejaculate, but you look at it under the microscope and there is very little or no sperm. So no matter who you are, or even if you've caused a pregnancy in the past, everyone who is planning to do a fertility evaluation, the person who is providing the sperm should have a semen analysis. And that is the way that we can make sure that there's sperm in the ejaculate. On a semen analysis, we look at the count, the number of sperm that are there. We look at the motility. That's like the ones that are alive and swimming and can get to the egg. We look at pH, we look at agglutination, we look at so many things. We look at morphology, or the shape of the sperm, because sperm that has a more normal shape has a higher chance of fertilizing an egg. So you get so much information from a semen analysis, and just don't skip this step. If you had to choose one test to do for a couple that's trying to conceive, and you could only choose one, I would do the semen analysis. It's one of the least expensive tests, and 30 to 40% of the time, a couple can have some sort of male factor contributing to a part of their fertility journey. And so just don't skip the semen analysis. And finally, anatomy. Okay, so we've made sure there's eggs, we've made sure there's sperm, and then we should think about anatomy. And as far as anatomy, I mean uterus, ovaries, and fallopian tubes. And it really takes 2 tests to really look at the overall anatomy: a pelvic ultrasound and a hysterosalpingogram. With the pelvic ultrasound, we can see the outside of the uterus and we can see the ovaries, but we cannot see fallopian tubes. And even if we could see fallopian tubes, we don't know that they're open. And we also can't really tell that the inside of the uterus, like where an embryo would implant, is okay by just a regular pelvic screening ultrasound. So the other test for anatomy is a hysterosalpingogram, often called an HSG. Hystero just means uterus, salpingo means tube, and gram means study. So hysterosalpingogram, HSG. Now this is a test to make sure the inside of the uterus is nice and normal and the fallopian tubes are open. And both of those tests together really give you the full picture of your anatomy. And I honestly wouldn't skip either one. Sometimes people have no history of pelvic infection, abdominal surgery, or anything that you would think would maybe cause scarring or blockage of fallopian tubes, but we are surprised and we do find it. It could be something that you might delay or maybe check later in a few months, just because sometimes it can be an out-of-pocket expense, but really don't forget about that test if you're really trying to figure out everything there is about your fertility. So a little bit more about both of these tests. The pelvic ultrasound is done with a transvaginal probe. And I know that that might seem a little strange if you've never done this before, but it is amazing how well we can see the uterus and the ovaries with a transvaginal probe. And talk to your provider about it if you're nervous about it. We try to make everything comfortable for you, but it is dramatically changed women's health to be able to see the uterus and ovaries so well. And when we do the vaginal ultrasound, we are looking at the overall shape of the uterus. We're looking for fibroids. Sometimes we can see uterine anomalies with the pelvic ultrasound. Sometimes people have like a heart-shaped uterus. Sometimes people have two uteruses completely, a uterine didelphys it's called. And so we're looking at the overall shape of the uterus. And then we look at the ovaries. So when we look at the ovaries, we're looking for ovarian cysts, things that might impact fertility. And we're doing usually an antral follicle count. We're counting the number of little resting follicles that are there, because that's a window into egg supply. The second test is an HSG, and this is a really important test to make sure that the inside of the uterus is normal and the fallopian tubes are open. This is the only way that we can make sure the fallopian tubes are open without doing surgery. And by what I mean by only way is you really have to see fluid going through the fallopian tubes in order to make sure that they're open. The fallopian tubes are so small, they're so delicate, you cannot see them on a pelvic ultrasound. And even if you could see them, it doesn't mean that they're open. So the way the test works is it's done with fluoroscopy, and that is basically little X-ray images on your belly while there is a little catheter in the cervix, and there's fluid going through the cervix into the inner part of the uterine cavity and then spilling out through the tubes. And we're watching that happen in real time with quick X-ray images through fluoroscopy on your abdomen and pelvis. Now, a couple things about the HSG. This is a study that makes a lot of people really nervous because there's a lot of information online about how crampy it is and how much it hurts. Nobody can tell you how this experience is going to be for you, but I can help prepare you. It can be crampy. The vast majority of people, as that fluid is going into the uterus and spilling through the tubes, there is cramping. Like there's an awareness. It's like, okay, my tubes are not used to feeling this fluid go through them. I am feeling this. There are some patients that do have a lot of discomfort, but when we're doing it, we listen to the patient, we talk about it, we, kind of help them through that process. And if it's too uncomfortable, then we just stop. Like, I don't want anyone to not get this test done because they're scared of the pain, because you should have a provider that listens to you and can help you through it. Okay. And most of the time people say, wow, it is not as bad as I thought it was going to be after reading on the internet. When you come to do the hysterosalpingogram, don't be surprised that the providers are wearing lead aprons, okay? Because it is x-rays. It's kind of like when you get x-rays at the dentist, you'll see people wearing lead aprons just because they do it a lot. But it's very little radiation overall. And common questions are, oh my gosh, is this going to like hurt my eggs? Or are we gonna x-ray my eggs? Honestly, no. There are a lot of people that actually conceive the same month as their HSG or even a couple of months afterwards. There's small studies that have shown improved fertility after the HSG. I can't really explain it. I don't really like use it as a fertility treatment, but I often share with people who are nervous, like, hey, we've seen this. And there must be something about just sort of flushing the fallopian tubes that, might get some mucus plugs or, something out of the tubes that allows the egg and sperm find each other. I can't say that for sure, but I can definitely say that I've had plenty of patients who have conceived the same month of their HSG or in a couple of months after. So just to recap, fertility testing is really the basics in that we're making sure that there's eggs, there's sperm, and the anatomy is okay. All right. So it's the blood test, the FSH, estradiol, AMH, the pelvic ultrasound, looking at the outside of the uterus and the ovaries to look at antral follicle count. And it's the HSG, hysterosalpingogram, to make sure the inside of the uterus is nice and normal. For that, we're looking for polyps, fibroids, scarring, anything that would affect implantation of the embryo. We're also making sure that the fallopian tubes are open. And then do not forget that semen analysis. That is one of the most important tests to do. There are other tests that are sometimes done, sort of preconception tests, other hormone tests. We will get to those in another video. I hope this video was helpful. I hope it taught you a little bit about fertility testing, whether you started the process or you're thinking about asking more questions. Please like, share, comment on this video. I'm here to teach. You can learn more by following me on Instagram, on TikTok. Please subscribe to my newsletter to stay up to date and stay here for more videos.